I'm going to actually hold for just a second before I ask my colleagues to introduce themselves and give all of you on the line just a little bit of background into what Impact is. This is a really new organization. Dime is absolutely delighted to host this with our colleagues at the American Telemedicine Association. We'll tell you a little bit more about the origin story as Anne and I get chatting later. We are also delighted to be joined by an extraordinary group of founding members at Impact, from sort of critical players in the tech stack like Microsoft, all the way through to patient experts who join us from large payer organization. We have a couple of the Blues and some really innovative payer organizations, through to a large variety of different virtual first organizations that serve and meet the needs of patients where they are across a variety of different therapeutic areas. So while you have Quentin, while you have Samir, while you have Anne, and while you have myself today, we do represent this extraordinary group of experts who have come together. And let me do something first. Let me introduce myself so you know who you're listening to in the context of this conversation. Then after I introduce Dime, I'll hand over to my colleagues to share a little bit about themselves and their organizations in particular. For folks who may not have attended a Dime webinar before, my name is Jen Goldsack. I'm the Executive Director here at the Digital Medicine Society, or Dime. And our organization is dedicated to advancing the safe, effective, ethical, and equitable use of technologies in the service of improved health. And that mission aligns beautifully with the work we're doing with all of the colleagues you can see on the screen and with our colleagues at the American Telemedicine Association. And the reason we came together here at Impact is we believe deeply in the ability for virtual first to meet needs of patients that we haven't been able to meet before. We believe deeply in the needs of physicians in some cases, not in all cases, but physicians to be better met by engaging in this type of care that doesn't always involve building care out from around the clinic, but rather combining high quality digital health products with communications technologies and with clinical expertise. And that's really important. Those are the three legs of the stool when we define virtual first, although we should definitely have some conversations about that when it comes to Q&A. And we use those digital health technologies, communication technologies, and clinical expertise to build care out from around the patient, not from around the clinic. And that's the difference. And we think about this as a spectrum, with virtual first really being built around the patient, with telehealth broadly, including virtual first, but in many ways being still sort of built out from around the clinic. And then your more traditional approaches where we expect the patient to come to the physician for that visit, for that encounter, for that test. Why were we excited? Why was the timing right for us to put Impact together? Why did we bring this extraordinary group of experts together to pursue this mission of advancing virtual first? There, you can see on the screen here, Kaiser has 2 virtual first health insurance programs that are currently active. United also just launched a virtual first program, and we're hearing murmurings from other payers that they are absolutely leaning into this. Why? Because they recognize the benefits in doing this from a provider point of view, from a patient point of view, most importantly, but also from an economic and efficiency point of view. And what we wanted to do was be very intentional, capture this moment, work with the leading virtual first organizations in the field to position virtual first as an evidence-based, patient-first way of delivering care, and as quickly as possible, putting it as part of the patchwork of options that are available to all patients, wherever they are. It's also really interesting, and if you haven't been following some of the phenomenal resources that have come out of Andreessen, actually their research shop has put some tremendous pieces out around virtual first. Technical questions around what's the tech stack needed to do this correctly, and thinking about virtual first as being a way to pull us away from, frankly, my opinion, let's discuss this, our obsession with the visit. That the doctor-patient encounter, whether that's synchronously through a platform like this or into the clinic, has proven a choke point for innovation. How can virtual first overcome that? And there's some really nice pieces coming out from Andreessen that are really aligned with how we're thinking. So with that, let me stop talking for a moment and let me ask my phenomenal colleagues to introduce themselves to you before we dive into a bit of a discussion and then call on you for questions. Anne, you are my partner in crime in hosting Impact. It's always a pleasure to work with you. Would you like to introduce yourself, introduce the ATA, and share why you're excited about being part of Impact?
Well, thank you, Jen, and it's great to be on this with everyone. I am very excited about Impact and what we're doing here and the movement that we've started. I am Ann Mond Johnson. I'm the CEO of the American Telemedicine Association, the ATA, and we represent over 400 organizations that are committed to the vision that people should get care where and when they need it, that when they do, it should be safe, effective, and appropriate while enabling clinicians to do more good for more people. And with that vision, I think it's very obvious why virtual first comes into play, because I think that it's safe to say the issues of access and ensuring that everyone gets care that's safe and appropriate, you can't do it without technology. And we have to really reorient our thinking from being brick and mortar only to really incorporating virtual and technology writ large.
Fantastic, and such a pleasure to be working on this with you, Anne. And I love how you describe the importance of thinking of technology as a tool, not as the be-all and end-all here. Samir, do you want to go next? Introduce yourself, introduce Oshi, and why you're excited to be part of Impact.
Yeah, sure. So I'm Samir Berry, Chief Medical Officer at Oshi Health. We are a full stack virtual GI company, and every patient that comes through Oshi gets access to a gastroenterologist, a nurse practitioner, health coach, a dietitian, and a GI psychologist on a virtual first format. I'm really excited about being involved with Impact just to further this field, deliver quality care to patients, and being able to be involved with something like Impact where we can really take all these companies that are really taking time, investing a lot of money and effort into developing virtual care the right way, and separating that from some of the other potentially less robust solutions on the market is something that really excites me about being involved with Impact.
Two things. Samir, I didn't realize that you had a GI psychologist as part of that full stack offering. I absolutely love that. That's very cool, and I wasn't aware. And I also like what you said about sort of the distinction between virtual first and sort of potentially less robust offerings. And I'm going to quote our colleague here at Impact, Lucia Savage from Omada, and she was talking a little bit about sort of trust in the platforms that virtual first organizations use to deliver care, and questions around sort of privacy and sort of data rights. And, you know, she's definitely faced questions, I'm sure you guys have, we'll dive into this, around, you know, what is sort of the privacy of the information we share? What are the securities of these platforms? And her response, which I love, is it's as secure as your doctor's office, because it is your doctor's office. This isn't one of the 300,000 apps that we've downloaded from the App Store, right, of spurious quality. Some are wonderful, but it's hard to know. This is your doctor's office. It's just virtual first. And so that's been really powerful, and I'm glad you brought that up. Let's dive into that later. Quentin, round us out.
Sure. So, hi, my name is Quentin Soulet Brugiere. I'm the co-founder and CEO of Dreem. My background is engineering, so trained in computer science and physics and chemistry. And I've always wanted to use my engineering skills to develop medical solutions abroad. And so what we do at Dreem is that we make sleep medicine accessible to everybody. So we develop new solutions, both for diagnosis of sleep disorders and for treatment of sleep disorders. And we commercialize the solution first in a direct-to-consumer approach. We validated our solution in its main scientific publication compared to the gold standard and the other standard of care. And so now we are more and more working with the healthcare players, for example, to validate new drugs with pharmaceutical companies, or now also to build a virtual first care pathway for sleep, because sleep is a tremendous field for that. And you can imagine some care pathway with both diagnosis, treatment, bringing all the digital tools with the doctors at the center of it and the patient at the center of it. And that's a very interesting new challenge for us. And that's in this context that I'm particularly delighted to be part of Impact and to think about all the challenges of virtual first care.
Fantastic. And actually, Quentin, I wonder if we can start by digging into that journey a little bit. You sort of articulate how sort of Dreem has been successful. You started by that sort of direct to consumer. Then I think, you know, and these are all words that are sometimes controversial, then I think perhaps would have worn that moniker of digital therapeutic. And now you're thinking much more about sort of the much more holistic approach to coupling the sort of evidence-based digital products that you have as part of care and moving into that, you know, what we're now defining as sort of virtual first. Can you talk to us a little bit more about that journey and why the timing was right for you to sort of lean into virtual first and move beyond the sort of product only?
Yes, of course. Well, obviously the fact that COVID happened made care virtual or made care digital, and the fact that care is becoming digital changed a bit the rules of the way care will be delivered. And that's in that context that first we've been approached by players, either hospitals or pharmaceutical companies again, to use our technology in the care pathway that became digital. And so for us, that's a good moment to think about how we can build a true care pathway that has the patient in the center of it. And so that's the moment for us. So for the journey, we went first direct to consumer. We iterated a lot of our product that allowed us to develop products that people want to use and were actually able to pay to use our device with a high satisfaction. That allowed us to validate our technology in the best scientific publications. And now it's this combination of our technologies that is used by in the healthcare industry and the COVID that made us want to be a virtual first care player.
I love that story, and I love that there are a few different triggers there. Obviously, we've all been, I mean, in so many ways, but in our sort of professional lives, been incredibly affected by sort of COVID. It's been a catalyst, and that's part of the story. But I also really liked, Quentin, how you talked about, you know, putting the patient at the center, and how we're now able to do that with these sort of evidence-based technologies coupled with clinical expertise. Samir, when we think about how sort of Oshi has sort of blown onto the scene in, frankly, sort of very recent months, how is your sort of origin story, if you like, a little bit different to the success that sort of Quentin and, wait for it, the Dreem team have had? And, you know, how sort of, can you tell us a little bit more about sort of the priorities you have on deck, your sort of recent achievements, and sort of how through different sort of access points, both you and Dreem have sort of established yourself in this virtual first arena? Oh, bingo, you're on mute.
Never done that before, but of course, this is the first time. Oshi started out as a patient tracking app. This was a couple of years ago, and it was really a symptom tracking, food tracking, diet tracking app for patients with GI disease. And while we had incredible engagement, we quickly realized that patients needed much more and that they weren't getting really the best use of what Oshi could deliver. What was great is we had a team, an engineering team, a sales team, a product team that really understood GI very, very well from the ground up. They understood the unique needs of this patient case and transformed the company from a symptom tracker to a full-blown virtual care clinic. And our priorities there were to totally prove that if you redesign care delivery from scratch without the boundaries of fee for service, you can really totally transform the patient experience, incredible patient outcomes, lower cost, and importantly, with a wonderful experience, not only for the patient, but also for the provider as well. So that's one of our top priorities, is to focus on being a place of choice to work for high quality providers. In addition to what a lot of the virtual care companies are doing, which is, you know, lower cost, improve outcomes, and improve the experience for the patient. Some of the achievements you mentioned, you asked about so far, very quickly, we've only been launched for about 3 or 4 months now. We've hired and scaled and cross-licensed a full care team. Unfortunately, due to the corporate practice of medicine, we can't practice across state lines. We launched a fully integrated clinic in 2 states. We have also launched a first of its kind study with a national payer customer, looking at workplace presenteeism, absenteeism, the patient experience, healthcare costs, GI outcomes for patients that are enrolled in the Oshi program. And then we also, over the summer last year, had a 10-week alpha program where we studied this model on a select group of patients, patients with GERD, which is acid reflux, irritable bowel syndrome, and inflammatory bowel disease. And we had incredible CSAT scores, NPS scores. More than 90% of patients had symptom control, and we had really good engagement with our tech stack as well, which was really exciting for us.
Samir, first of all, congratulations. Second, I didn't know you had that Symptom Tracker app. It's really interesting to think that actually, obviously a different kind of technology, but that sort of both you and the Oshi team and Quentin and the sort of the Dreem team came at Virtual First because you realized that sort of the technology out in the wild by itself, without sort of integration into the clinical workflow, was not optimized for either the patient or for the provider. And I really like how sort of those insights have fed into some of our priorities at Impact, and we'll get to that a little bit later. And something that I didn't necessarily see at the beginning, so you were right, I may have been less right, was making very sure that we didn't create additional silos and drop Virtual First off to one side. And I'm incredibly proud of sort of the many ways in which I'm an ATA partner, but in us sort of co-hosting this, it was very deliberate. And I want to sort of credit you for some of the strategy here for how can we make sure that we do the work to sort of foster best practices in Virtual First, to truly understand it, but also to make sure it's really aligned with some of the other policy priorities and the sort of broader needs of this sort of patient and the healthcare system. Do you want to talk a little bit about sort of how within the work writ large at ATA you see Virtual First, and a little bit more about sort of the strategy as frankly you laid it out?
Well, thank you. And it's serendipity. Sometimes you are put together with someone and you realize that 1 + 1 does equal 5. And I think that's a lot of what happened with us. It's been great fun. And I think it's been, sorry about this, but impactful, and will be increasingly impactful. Yeah. A couple of things. One is that the ATA, we have a big focus on policy. So when we talk about DIME really being action-oriented from a research perspective and just having a very deep bench in that regard, the ATA has increasingly focused on policy. And with the pandemic, we're obsessed with the fact that we want to make sure that telehealth, broadly defined, is not viewed as a pandemic-only tool, which it's at risk of. And that secondly, that we know that we can use technology and telehealth virtual services to address some of the real raw, horrid disparities that have emerged. So the pandemic was an accelerant, as you said, for many of these things. So that's something that we focused on. So Virtual First, if you will, I think is a very clear component of where we are on the continuum, or where we want to go on the continuum, recognizing that, brick and mortar, this obsession with brick and mortar, what I call our edifice complex, is not sustainable for the US or the world at large in terms of making sure we fulfill the needs, the healthcare needs of our populations. And so, taking these complementary skills and the focus that the ATA has on ensuring that good laws get passed and bad laws don't at both the federal and the state level has made it pretty clear that, there's a lot of complementary effort there. And what I love about it is that you could have gone off and done this separately, or we could have gone off and tried to do this separately. But I think together we're acknowledging that both parties bring a lot to the table. And I think we have a commitment, we have an obligation as two organizations and through Impact to demonstrate that virtual is not second-class medicine. We're not delivering second-class care. And so we've talked a lot about some of the myths associated with what we're doing, and collectively we have to dispel them. So that's another area that I think we can focus on. And then, really this idea of, the technology, what we're delivering here is not technology, it's healthcare. And so I think we have to be really clear about that as well. So I'll stop there and get into the Q&A and so forth, but excited to be here. Thank you.
Of course. And for folks on the line, I'm watching the chat box, I'm watching the Q&A. As you have questions, just drop them in as you go. We have some ground we want to cover here, but we will keep an eye on those questions and flag them as they come in. And I really liked how you sort of described that. And certainly, Quentin, Samir, and you all know I'm like the ultimate sort of like nerd. One of the things that gets me sort of really excited about virtual first, and then we're going to take a walk down memory lane here. Well, not living memory, but let's do a history class. It took about 20 to 30 years after electricity was introduced to actually see any improvements in manufacturing. Why? Because manufacturing factories were laid out around the drivetrain, really nerdy, around the drivetrain of a steam engine. And so when electricity came in, they just put in an electric sort of source that was exactly where the sort of steam engine had been, and they didn't do any reconfiguration. And it was only like the new factories that came in and finally came up with the idea of the production line when electricity actually made a difference to manufacturing. And so I want to draw the parallels here, and I'm curious to hear what you guys think about this. Like, that's what I think virtual care can do. For all of you guys, Quentin, Samir, for all of our colleagues at Impact who are thinking about virtual first, there isn't the burden of re-engineering the existing workflows, the existing practices, the existing staff in a clinic, in a hospital that are engineered around the visit. And even actually, Anne and I did some terrific research with our colleagues at the COVID-19 Healthcare Coalition. We did a nationwide physician survey. This statistic blows my mind. Of all of the telehealth that happened during 2020, only 11% of those encounters used remote monitoring of any kind. Now, I don't know what the perfect number is. I actually don't think it's 100%, but that felt really low. And when they did use those, 40% of the time, the doctor only reviewed that data in the moment of the visit. So that's why I think like our sort of factory re-engineering model is worth bringing up, because I think virtual first can stop healthcare in the digital era taking sort of 20 to 30 years to be re-engineered. I think that virtual first can build it from scratch. You said this, Samir, sort of can write the blueprint, and that's going to be sort of a forcing function. It doesn't mean everything is going to become virtual first, but all of those lessons we learned can then go on to sort of a spectrum of care that is built around the patient, not the clinic. That's my hope. I wonder if any of you guys have reactions to that.
I mean, I think our current legacy healthcare system really emerged and hasn't changed for decades. It's still designed around the needs of the patient, like you said early on in the invention of electricity. Our system today is still designed around the needs of the patients 30, 40 years ago. Even the way we train as physicians, for example, is incredibly siloed, right? You train as like a surgeon or a proceduralist or a medical physician. And so this industry hasn't really gone through a restructuring to fit the needs of today's patients who don't want to get care in the hospital, right? Many, many decades ago, you wanted hospitals in every single community and every single geography because people were in the hospital for weeks and weeks. They needed to be closer to their families. Today, that's no longer the case, right? A lot of care is delivered in the outpatient setting, yet we have a system that's really designed around the inpatient setting, for example. We also have a system that's not at all designed around patients. And so one of the opportunities for these virtual care companies is to, from the ground up, completely redesign care delivery without being encumbered by that traditional care model, like you said, which just really is not going to make as much of a difference. The example you gave about RPM specifically, we can layer on all these small little incremental policy changes, improve, reimbursement for remote patient monitoring and things like that. But if the underlying structure stays the same, where physicians are paid on a fee-for-service basis, We're not measuring outcomes. We're not delivering care in an integrated model where all the team members needed to deliver care for a particular disease work together. These sorts of like incremental policy changes won't really, they're just going to kind of scratch away at the surface. And so what's exciting about virtual care is it's not just digitizing the old way of practicing medicine, right? If you digitize a broken system, you're just going to get a super efficient broken system, which is what we're doing. The traditional telehealth in a way is doing that. And so I think what's exciting is not digitizing the old system, but redesigning it from the ground up. With virtual first. That's why I always like to say virtual first. Oshi and a lot of the other companies, they're not just telehealth companies. They're really redesigning care delivery. Telehealth is just one small component of it.
So I would just add on to that, because Samir, you touched early on in your prior remarks about moving away from fee-for-service and being more in a value-based environment, which I think is something that we're very strong on. We think that that's absolutely critical, because virtual digital health does really well in a value-based environment. But in fee-for-service, if you're thinking nickel and dime, it's not going to hold its own. I would say the other, though, is that what's changed is, yes, there's at one end of the spectrum, there are the virtual first players, such as both of your companies, that have started, that are building incredible momentum by not digitizing the way things have been done in the past. But there's also been this whole raft of experience from both consumers and clinicians about experiencing digital services and recognizing that, oh, it's not just for, checking your sore throat or seeing if your kids can go to school tomorrow. It really has a place in a broad spectrum. So that's why it's important not to shoehorn, as Jen says, remote monitoring into synchronous care, and ensuring that we really expose all this as it comes together and really, again, address this issue of access, which we have inadequate amounts of, and consistent quality, which again, we haven't had in the US at all.
I think, I think, go ahead. Yeah, no, I agree with all what has been said. And I think indeed the fact that all the changes that we've seen in the consumer space, all the technology that has been developed on the consumer, I think the way now it's used by companies that are doing some clinically validated solution, all that can be built in an integrated care pathway, and somehow the healthcare field has always had a delay of innovation compared to the consumer, for good reasons. That's the same thing in space. For example, the platforms that run the operating system are usually operating systems that are 10 or 20 years behind what is used by consumer. And it's perfectly normal, because we need to be sure that the technology that is going to be used in the healthcare or in the space industry is completely safe. So traditionally, healthcare has been a delayed technology, and everything that has been built and validated and showed that we can change behavior, measure data accurately, have a diagnosis, have a treatment that works efficiently. Now it's coming to be validated enough by doctors, by the FDA. So regulation is starting to exist around this new product, helping companies like us position ourselves in this more regulated space. And the trend was coming already. And I think, again, that COVID, because it made everything virtual, has been an extraordinary accelerator for virtual care, first care. So definitely for us, that's a great opportunity to be able to build something from the start. And because the regulation now exists to place a company like ours in the patient care, in the care pathway.
Quentin, I really like that you drew that out, because I think, as with any of these sort of opportunities, there have to be a sort of a couple of different triggers that lay the groundwork for this kind of change that we're talking about. And I think you're right. I think the technology that we're reliant on has reached a level of maturity that we can evaluate it and we can truly call it and prove it to be high quality. There's been the push factors from sort of COVID. There's been the sort of consumerization of healthcare generally. There's been, frankly, and Samir, you keep, and I'm glad that you remind us of this, obviously we want to deliver the best care to patients, but at the same time, we want to make this a good experience for physicians and clinical colleagues generally, and we know that they have been struggling. We're starting to get some really tremendous questions in, so let's turn to our audience and let them guide the conversation. Ravi, you put a great question in the Q&A. I've just unmuted you. You should be able to unmute yourself at your end and ask your question directly to the team.
Okay, I hope you can hear me.
We've got you.
Great. So my question was, I guess this is for Anne. What policy changes are we working on to create a one-to-many healthcare delivery model or asynchronous delivery models? Because I assume that's the kind of redesign we're really talking about.
So we are, and thank you for the question, Ravi, we are fighting on a couple of fronts. And it is sort of, I was incredulous to, when I first came into the industry, to understand that we have regulations that were created that govern what we do with telehealth, that were created before the iPhone was even invented. So you can see the disconnect between regulations and technology. So I would say one-to-many, we're looking at things like eliminating the originating site restrictions at the federal level that still exist. The fact that, you have situations where in 50% of counties in the US, and I use this statistic a lot because I think it underscores the problem, 50% of counties in the US do not have access to mental health services and physically, and yet 1 out of 5 Americans pre-pandemic had a mental health issue. So the regulations that we're dealing with are at the federal level pretty fundamental. And then the second thing that we're fighting at the state level is some restrictions that are, or regulations or laws that are proposed that really make it difficult for you to be able to even embark on a virtual care pathway with your clinician. And it's rooted in this idea that somehow patients aren't safe unless they have an established relationship with a clinician that's established face-to-face. And that's just not the case. We've shown time and again that you can establish relationship using technology, and you do not physically have to be in the same room. So I think that the laws and the work that we're doing at the policy level is even more fundamental than one-to-many. It's really recognizing that, yes, one-to-many is one of a few battles that we're fighting right now. And again, instilling a sense of urgency among lawmakers is really our charge. It's part of what we're trying to do.
Is there a follow-on question that I can ask? Can you still hear me?
Yes.
We've got you, Ravi. Go ahead.
Okay. So the question is, I know what we need to do. How can you get more people in the field engaged in pressuring the legislators in the process? What kind of efforts are you undertaking to make that happen?
So I think it's a great question. We've launched a campaign within the ATA last year where we had members engage with us, and our priorities were primarily at the federal level. This year we launched another campaign where we're working at the federal level as well as the state level. And I invite you to check out our website, see what we're tracking at the state and the federal level in terms of legislation. We have policy webinars, and then we have call to actions. There are a number of different things that we're asking folks to participate in. You'll see some other things get announced in the next couple of weeks, and we'll be sure to get it out to Impact and our DIME partners as well, because this idea of creating political will to use things as simple as social media to make sure we put pressure at the state, specific folks at the state level as well as at the federal level, are things that we're going to ask your help on.
Thank you.
Thank you.
Ravi, terrific questions. And folks on the line, I actually just popped a link in the chat. You can sign up for the Impact newsletter We don't spam you. It's maybe one a month. And we'll keep you up to date on all of the happenings at ATA that Anne mentioned. Ravi, terrific questions. Thank you so much. Andrew, you've been asking some terrific questions in the Q&A. Do you want to, are you somewhere where you can unmute yourself and pose them directly to Quentin and Samir?
Sure thing. Can you hear me all right?
We've got you.
Great, thank you. So yeah, a couple of interrelated questions that are about trade-offs in designing a virtual care model, right? Patient engagement and patient experience are critical. Can't get anywhere if you don't have that. But these models also, have the promise to be very efficient and scalable through the use of digital technology and automation and not being 100% dependent on humans. But we also know that a human touch is critical for engagement. And so the two questions are about, first, what aspects have you found in designing your own models are the most impactful or powerful in driving patient engagement and satisfaction? And there's kind of an implied hypothesis there that a lot of that might be the human element. And then second, how do you strike that balance between making sure you get that patient engagement that you need while also building something that is scalable and efficient and automating where possible?
Yeah, no, I think you're completely right. And I think that's, I agree with all what you say. Indeed, so Humane Touch is compulsory to have good engagement and good satisfaction. Internally, we've got trained psychologists to deliver CBTI, and so we've got part of the content that is delivered on the app, and part of the content that is delivered by our trained psychologist. And so the question is the right balance that you need to have between technology and human. I think it's pretty hard to answer, to give a general answer. For us, it has been a lot of iteration and a lot of tests to try to increase the satisfaction and see. So one thing that you can do is that one solution is not necessarily the same for all the patients. And for example, we can see if a patient starts to drop the therapy or be less active, and then we propose him to have a call with one of our experts. One other thing that we do is that, for example, our psychologist works very closely with the product team. So we are sure that the product that we build with the digital therapy is completely linked to the human advice that the person is going to have. And that's a big challenge, or that has been a big challenge for us, to have something that is completely integrated between both. So in one word, I would say that there is no easy answer. You need to test and to see what gives good results in the end, and then see what can be scaled. And so you have this equation between more or less human interaction. More human interaction means more cost and less scalability. And so you need to find the right balance between having high patient satisfaction, high treatment efficacy, but on the same hand, something that can be scaled. So yeah, one word answer, test and iteration.
Yeah, and I'll add to that. I don't know if it's necessarily a trade-off either, just because of the technology that we have with regards to your question on scalability, efficiency, automation, and balancing that with the engaging patient experience. I think it's about appropriate use of your resources. The traditional care models, providers such as myself, care coordinators, psychologists, dietitians, we're spinning our wheels doing so many things that are not really directly impacting patients. And so if you design a virtual care company with the right tech stack to enable your providers, your care coordinators to really operate at the top of license, you can actually use more provider time with patients. And on the back end, your total provider time isn't really changing. So I don't necessarily think that there's a balance or a trade-off there between patient experience and using your resources efficiently. It's just understanding what your patient's needs are and then actually delivering on those needs and trying to remove the barriers that the traditional system has developed to enable the company to do that. The second part of your question about patient experience and what's been most powerful in driving patient engagement, again, it's just about understanding where the friction points are for the patients in today's model, right? I have patients who come and see me who have driven 1 or 2 hours, arranged childcare, parked and walked 20 minutes around our hospital, and then come to our clinic for a 15-20 minute visit, and then they don't see me again for 6 months. If we can have high touch points with the patients between even our virtual visits, that dramatically improves the patient experience. So if we can ping the patient and let them know, hey, we sent you a at-home blood test, We want to make sure your inflammation levels are okay, or even use data for something as simple as like a patient's birthday, and our health coach checking in with the patient saying, hey, we noticed your birthday is coming up next week. Make sure you stick to your diet, make sure you stick to avoiding these foods that we know will drive your symptoms. Those types of very minor touch points make dramatic improvements in patient engagement. So for us, it's just, again, in summary, understanding the patient's needs, delivering on those needs in a way that's incredibly convenient for them. So using in-home care, in-home labs, check-ins whenever we can. And then again, I don't think it's necessarily a trade-off between efficiency and an engaging patient experience.
I really like that, thinking about it as sort of a yes and rather than an either or. I think that we are sort of affected in sort of digital innovation in healthcare by a variety of different sort of false dichotomies, and I think that's one of them. Andrew, did the team answer your questions before I move on and actually call on Rachel? Is there anything else you want to ask and follow up?
No, that's it. Thank you very much.
Terrific. Andrew, thanks for being here. Terrific question. Rachel, I've just unmuted you.
I'm here.
You put a couple of great questions in the chat if you want to go ahead.
Yeah, sure. I'll go with my second question first. Hi, everyone. Thank you so much for this fantastic presentation. My question is something that I know that Anne touched on previously, and something that I know that we are all thinking about a lot. So now, thinking specifically about telehealth, we saw with COVID-19 that disparities to access were large, specifically with many groups, primarily non-English speaking, female, older, and lower income patients. What is Impact and or your companies doing to lessen virtual healthcare disparities regarding virtual first care as we all move forward?
I'll grab this quickly at a high level. And I think one of the most important things to say, Rachel, is that's very much on our roadmap. It's values that both ATA and DIME sort of bring to the table as sort of organizations that support the field. And, frankly, if every single one of our member organizations didn't reflect that value too, they wouldn't be a member. So we have created this community where that is top priority. That's fine. And Rachel's a turn of phrase that you shared with me that I believe our colleague Victor Chan at Genentech shared with us is, and what are we doing to make sure we're not just admiring the problem, and actually actioning it? And so when we look at our priority programming, when we think about positioning these organizations, it's sharing of best practices. It's making sure that our member organizations are encouraged and supported in always sharing the approaches that they are using. I know that some of our colleagues out in the field, our colleagues at Onduo, for example, have just introduced their entire offering in Spanish sort of across the country. I know our colleagues at Livongo, for example, a lot of their monitoring technology is 2G technology because the data packets required are much lower. I know that Anne bangs the drum tirelessly along with Joe Caveda over at ATA about, we have to be willing to think about voice only. And, one of the sort of the values in every single one of our sort of programming initiatives is equity and access. I will be honest, and I'm curious to hear from from others on the line, we do not have a single initiative yet devoted to access or to equity, but rather as we look at our priority programming, it's woven through as fundamental to everything we do. That's how we're thinking about it at Impact. Quentin, Samir, how are you guys thinking about it at your organizations? What can we learn from you all today?
I can take it, Quentin. So it's a great question. It's something we think about all the time. And I agree with Jennifer. It's really just baked into the core ethos of what virtual care companies are doing. I'll give numerous examples. So the example I gave earlier about a patient who has to arrange childcare, taking time off work to come and see me, virtual care really limits those barriers for the patient. It allows them to maybe take their visit while they're at work, not having to arrange for childcare, evening visits, weekend visits. So that's one aspect of it. The other aspect is, I think, because there's so much cost savings in virtual care without having to go through the inefficiencies or the fixed costs that are required in a brick and mortar model, that it enables us to have high touch points with the patient and understand how the care team's recommendations fit into their individual lifestyle. So for example, if you have a meeting with a patient and you tell them, okay, you have to stop eating all these foods and start eating all of these sometimes expensive foods, for example, that's a very common recommendation given in a standard GI clinic. At a company like Oshi and a lot of the other virtual care companies, because we're able to spend more time with the patient, utilize providers like health coaches, we can understand the patient and understand, okay, this patient cannot follow this diet for whatever reason, whether it's a socioeconomic issue, an issue that has to do with their job, and really start to personalize and fine tune the recommendations for each and every patient. The last thing I'll say is, traditionally, integrated care delivery, and when I say integrated care, I mean care delivered by multiple different specialists, all trained in that one patient's needs. So for example, for a GI patient, the research has shown for a decade that you need a dietitian, a GI psychologist, a gastroenterologist, sometimes a physical therapist, who are all only seeing GI patients and have really deep expertise in this type of disease. Unfortunately, these types of teams are only available at tertiary, quaternary academic centers. And so, the vast majority of patients who live in the inner city sometimes or in rural areas, they can't access this type of care. And so virtual care companies really have the opportunity to democratize this type of care delivery and pull it out of the academic ivory tower and really make it available to everyone.
Samir, that's really well said. And Anne, you and I talk sometimes, about our goals sort of collectively at Impact and elsewhere is, what can we do to make the Dartmouth Health Atlas sort of monochrome, right? How can we stop seeing disparities in sort of health outcomes by place and all of the things that we know contribute to that? Quentin, are you thinking about this at all with your work at Dreem? Is there any sort of remarks we want to add before we head on to our last questions for the day?
No, I can agree with what has been said. I think indeed virtual first care can give better care at a lower price, and that's something that in the end it might take time to be covered by all the payers, but in the end, if the price is lower and the results are higher, that's care that is going to be more widely spread, and I think that's really what we can do. There. After that, so that will take time, of course, before it's completely democratized and before everybody can have access to it. But that's the same thing with all the innovation, I would say.
I could, Jen, there's two organizations that we've chosen to join, two coalitions. One is Telehealth Equity Coalition, and the other is Health Tech for Medicaid, which is headed by this other dynamo person, Adamika Arthur. Our concern on the Medicaid, and the reason why we've engaged with both, but particularly with Medicaid, is that, for all the virtual first companies, trying to get reimbursed for your services is a challenge, or sometimes is a challenge. The second is that with so much pressure on states with budgets and, the shortfalls that they have, you're going to see Medicaid programs, cuts being made with blunt instruments instead of sharp knives. And it's really incumbent on all of us to prove how what we're doing is cost effective and really can have a huge impact, because it should be part of what is offered to people regardless of what insurance program they're in.
Rachel, thank you so much for the really important question and for pushing us to sort of share and take a position on all of this. That's something we'll always strive to do at Impact, and I'm really glad you asked. Thank you. We're going to have a couple of quick fire questions before we wrap, and we'll definitely let everyone go on time. Ellen, you put a couple of terrific questions in the Q&A. You should be able to unmute yourself and give that voice.
Okay, this is Bonnie Feldman with Ellen. Can you hear me okay?
Yep, we've got you.
Okay, so my question, probably Samir can start to answer this one, focuses around the needs of chronic disease management patients who often see multiple primary and specialists, but There's also this problem of being misdiagnosed or underdiagnosed where physicians can miss severe problems. And so I'm curious, in a virtual first model, how you would approach these kind of situations that can often lead to serious malpractice concerns, even in on-site visits, and how virtual first would be thinking about this.
Yeah, well, oh, go ahead.
No, go ahead.
The first thing I'll emphasize is, virtual first is not that different or different at all with regards to your question, right? We are a full medical clinic. We have licensed board certified providers. We have an EMR. We order labs. We order procedures. We order imaging. We follow up on those tests. We order medications. So very similar to the brick and mortar world, the same operational care pathways are being done in both worlds. Now, with your regards to missing certain diseases, there's a risk of that, a baseline risk of that happening both in the virtual world and in the brick and mortar world. I think virtual care companies have a much better understanding of their data. They have a much better understanding of what to do with certain patients because they have the time to spend with those patients. To touch on the question from the last participant about reimbursement models and insurance companies, this is related, I think, to potentially missing a diagnosis. Companies like Oshi and other virtual care companies have built their systems outside of fee for service. So we ask for one, monthly cost per patient, and then we determine what the best use of that money is, whether it be spent on diagnostics, on ancillary providers, and that enables us to really follow the most cutting edge research without having to go through hoops of begging an insurance company to get a certain test approved. It just allows us the freedom of practicing medicine the way it should be practiced.
Thank you.
Fantastic. Ellen, that was a terrific question. I appreciate it. Ben, I want to make sure that we give you an opportunity to ask your question about sort of chain of accountability. That's a question I haven't heard yet, so I'm keen to learn from you.
Hi, everyone. So it's probably something that cuts close to the answer that Samir was just giving. So the idea that virtual first versus brick and mortar is not so different in terms of determining who is responsible for what aspect of patient care, I fully follow that, and especially with a company like Oshi, where you're not trying to fit stuff into the steam engine anymore. I can clearly see how that is working, and how that is kind of sidestepping the issue. But to give one specific example, about 6-8 months ago now, we rolled out a post-hospitalization COVID-19 telemonitoring solution. So basically, a number of devices go home with people. They get discharged from the hospital faster than they normally would because they have a telemonitoring solution to keep an eye on them for a few days. This was rolled out in Europe, so that might change the answer a little bit. But the general idea, or the general feedback that we constantly got from the physicians involved with the care of these patients was, okay, this is great, we love this, but who is responsible, right? This is, of course, a very specific problem, but if you try to zoom out a little bit, there's going to be a lot of care pathways, classical care pathways that require brick and mortar that will be adapted for a virtual first approach. And I can imagine that this is a question that will keep popping up over and over again. So I was kind of wondering if the panel could comment on that, and specifically if the ATA, for instance, is engaging with policymakers and regulators to figure out how to come up with a more robust solution than a, let's figure this out on a case-by-case basis.
Well, I'm going to let Samir answer first because he's nodding his head vigorously, and I think he's given this probably more thought.
Yeah, I mean, it's something we think and talk about all the time. So I think we just have to take a step back and ask these sorts of basic questions about the underlying structure of the system today and how, again, we can redesign care delivery completely from the ground up. With regards to your example about remote patient monitoring, for example, if physicians are getting access to all this data, pulse oximetry data, and they don't really know what to do with it, that's a huge problem. And so we've been very mindful of designing any sort of high touch point we have with the patient and the data we're collecting with a contingency plan as to what to do with that data. Your example around malpractice and responsibility, I think tort reform in this country, malpractice tort reform, is something that has to occur anyways, regardless of whether we whether virtual care explodes or not, tort reform is a huge problem. One thing I think that virtual care companies are able to do, again, because we're not encumbered by this fee-for-service model, is we don't have to sit there and write these defensive, purposefully vague notes with this malpractice defensive medicine practice in mind, right? We communicate with all the providers on the care team on an hourly basis through Slack, through video chats. We're on the phone all the time discussing our patients. So the note is really there just as a hallmark for that provider to remember at the next visit what was going on. It's not used in the traditional sense of communicating between providers, defending yourself against any kind of malpractice issue, or justifying the ordering of a certain test. We do that in ways that are more novel and more just 21st century, I guess. But I think in summary, tort reform is something that has to occur regardless of where virtual care goes.
So I'll just jump on that real quickly if I could, Jen, and that is that, we have clients that have discharged patients home with pulse oximeters and so forth, and to great success. So people are staying out of the hospital, which is what everybody wants. The second part of this is looking at some of the async players like HIMSS and Row and GoodRx that have operated in this environment and are absolutely much more thorough in their assessment of patients than one might have been led to believe previously. So I think that there is a fair amount of accountability, and part of what we do is on the policy side, but also just exposing and really calling out the good practices that these are companies that, adhere to standards of medicine, just like anybody else.
Fantastic, Ben. That was a terrific question and a great one to end on. Quentin, Samir, and thank you for being with us today. Thank you everyone for being on the line. The quality of the discussion was terrific. It also, I think, one of my takeaways will be we have a lot of support in being very intentional in terms of how we develop and roll out and share learnings from sort of the evolution of virtual first. So thank you for everyone being on the line. I did drop into the chat the address where you can sign up for the Impact newsletter, and through the Impact website at impact.dimesociety.org, you can stay up to date. But with that, Quentin and Samir, thank you so much for joining us today, for taking the time. Have a wonderful day, everyone.
Thank you.
Thank you.
Bye-bye.
Thank you. Have a good day.